For the first time ever, researchers, policymakers, and implementers gathered in Mexico City in October 2015 to share new evidence, identify opportunities, build understanding across disciplines, and discuss the way forward to improve maternal and newborn health around the globe.
Like my colleagues, I think we have realized over time that it is extremely important that we broaden our thinking to include mothers and newborns when we discuss the issue of care.
I hope you leave here inspired, more knowledgeable, and more than anything else, more passionate about ending preventable maternal and newborn deaths.
The MDGs represent one of the greatest achievements in the history of international cooperation.
USAID has been putting forward a new financing framework to look at sustainable financing, public and private, global and local. And it's also in that context that we have seen this year the launch of the new Global Financing Facility for Every Woman, Every Child.
In some regions of the world, mothers don't name their babies during those initial fragile days, afraid that their baby may not survive and that the pain may be too much to bear.
Now is the time to actively make both mothers and newborns a priority.
Without a doubt, the MDGs can be considered a resounding success. So for hundreds of millions of people in the developing world, life is much better. But we can't stop until life is better for everyone.
As we go forth with the SDGs, that the issue of gender equality becomes central to our consideration, because it is what is going to change the space.
What about half the child mortality is within the first month? And of that, most is even first day in the first few days, you know? But then when we come up here in the poorest countries, then we drift away, and we still have countries where there's so many low-hanging fruits which can be solved by the interventions for 1 to 4 years old. But those low-hanging fruits are now in remote areas. They are low-hanging, but they are far away. You have to go all the way here to get the vaccine to the people over here.
I think we have to reshape all our pre-service education programs so that we are producing highly capable individuals immediately on graduation.
Midwives need doctors, and doctors need midwives. And I'm talking about every healthcare professional.
So investment, technical support units, demonstration sites, and above all, a quality of care movement for mothers and babies. That's what I want.
One of the reasons why we are interested in integration is because we have done such a great job of creating vertical programs in the last decade. Very well-funded programs, some of which are successful, some of which can be disputed.
The way most governments are organised has reproductive health one place, child health another place, newborn health lost in between or maybe in the car park. So the biggest barrier to integration for maternal and newborn health, my friends, is not the mother and the baby, it's us, the global health community.
Many country health information systems, like many of the roads we see around, in Africa and elsewhere, in this context, they just stop at the facility.
If we don't organize ourselves at the global level, it will be very difficult to organize a poor midwife in the rural area that has 500 things to do.
When a woman comes to a health facility and she is offered integrated services for both herself and the baby, she becomes a satisfied user. And because she is a satisfied user, she becomes a champion in the community.
Who you are or where you live should not be a factor in if you live or receive services.
So more and more of our work, all of us around the world, is in situations of conflict, fragile states, people on the move, huge issue now for all of us in many, many countries. And how are we going to deliver programs and services that are actually going to reach people in those hardest to reach circumstances.
Exclusive breastfeeding is the only intervention that we monitor that the poor do better than the rich. And unless we protect and support the poor, they may well end up doing less well than the rich.
In all too many countries, health systems reflect the same and refract the same inequalities and patterns of discrimination that there are in the overall societies. Health systems in low-income, middle-income, and high-income countries.
When children get vaccinated, they become healthier. That really unlocks a huge virtuous cycle of prosperity, peace, and economic productivity for societies, communities, and nations.
But for women to be able to deliver, society has to deliver for women. And it's health, including maternal, newborn, sexual and reproductive health and rights. It's education, more than primary education. It's economic empowerment. It's political participation.
As we apply learnings from decreases in maternal morbidity, in maternal mortality, to the situation of newborns and stillbirth, with hopefully equally positive results, we cannot overlook these conditions. There are clear markers of poor quality of care and inequity that we need to invest in until we eliminate all those that are preventable.
With the right leaders, with the best evidence, with skilled health professionals, and with demand from the public, rapid progress, historic progress is possible in women's and children's health. It is right now our moment to resist, to organize, to advocate, to protect women and mothers, to prevent stillbirths and newborn deaths. It's time to take action and fight back.